Very interesting first discussion that we had. Let's move on to the next part of the session, which is case presentations. And it is my honor to introduce the first presenter for this evening, that is Dr. Vishal Agrawal. Dr. Agrawal is Associate Professor at Jaipur in SMS Medical College. He is very young. He's had 10 years experience as faculty and teacher, but despite his youth, he's an excellent clinician. He did his FRCS from Glasgow and ICO Clinical Sciences in 2010. He also did his post-graduation from RP Center in AIMS, New Delhi, and his vitreoretinal fellowship from Shankar Netralaya. He has presented at various scientific meetings. You may have heard his presentations before. And he has co-authored several books in his subspecialty. And he has more than 20 peer-reviewed publications already to his credit. And his forte is that he performs light surgeries at various national conferences, and he's also on the editorial board on IGO. So we look forward to the first presentation by Dr. Vishal Agrawal.
Welcome, Vishal.
Thank you, sir. Ma'am, can you stop? Yeah. Thank you, madam, for the kind introduction, and thank you. Can you see my slides, sir?
Yeah. Yes, we can.
Yeah, thank you, Dr. Partha, sir, and AIOS for having me here. So I'll be discussing the topic given to me, that is cataract and multiple PED. I'll be sharing my experience of two interesting cases in brief. So the case one was the patient was a 63-year-old gentleman, and he had bilateral cataract, nuclear sclerosis grade 1. The vision was fairly good. It was 6/12 in the right eye and 6/6 best corrected in the left eye, and the near vision was N6 best corrected. And he was referred to us for a fundus examination because there were multiple drusen's in both the eyes. The right eye had multiple drusenoid PEDs and had a old epiretinal membrane, and he knew that from a previous consultation also. And this was way back in 2017. This is the right eye of the patient, and this is the left eye, which I want to focus on. And this also had the similar picture without the ERM. The vision was around 6/6, 6/9 best corrected, and the patient had multiple drusenoid PEDs, large colloid PEDs in the posterior pole. And the patient was having the only complaint of slight metamorphopsia. Otherwise, he was able to read and see in distant very clearly. So we followed him. There was no fluid in any of the scans performed. So we followed him closely every 3 months. This was a June 2017 scan OCT of the left eye, showing the same picture with no fluid. And then he came in January 2018. The vision had deteriorated to 6/12 parts, and the cataract had progressed to nuclear sclerosis 2, and he was advised cataract surgery at that time. And before doing this surgery, we scanned him again carefully, and in every section we did FFA also, and there was no fluid in any scan. And this was the this is the video scan of the left eye OCT. So as there was no activity, the macula was dry, and the picture was the same as it was 2 years back, 1.5 years back. We went ahead with the uneventful phaco-IOL in the left eye. After 1 month of the phaco-IOL in February 2018, the patient presented to us, and now you can see closely the changes. To a cursory glance, it might seem that there is no change, but if you look closely, so the yellow arrowheads, indicate the fluid intraretinal, and the red arrowhead, show the hyperreflective dots which Dr. Atul was mentioning. And the green stars, is the activity in the previous pigment epithelial detachment, which was not there, with increased transmission. So there is an activity. There was a speck of hemorrhage at that point at the fovea, and the vision had dropped to 6/18 parts. The treatment was, of course, left eye intravitreal injection, ranibizumab 0.5 mg, 0.05 ml. 3 loading doses were given, and after that, PRN regimen was followed. The last follow-up, he responded very well, but then again there were recurrences, and this was the last follow-up before he dropped on the consultation, and there was still some fluid left, and he was advised injection, but he did not turn up. Case 2 is a 70-year-old female with bilateral cataract, nuclear sclerosis 1 to 2. The right eye vision was 6/6. The left eye vision was 6/9 parts, best corrected. Again, referred for fundus examination for drusen's in both the eyes, and the patient did not have any complaints slight metamorphopsia, and this was the fundus picture in 2016, the first consultation in January 2016. As you can see, it's a mix of soft drusense and some cuticular drusense, and there is a speck of scarred CNVM on the superior part of the fovea. But on the OCT, there was some cuticular drusense, some PEDs, but no activity. So this was a HD scan. So this is a screenshot because your macular cube video can be captured, but not a HD video. So that did not show any activity in any of the scans. Again, regular follow-up. So the patient was very particular about the follow-up, and there was just a slight metamorphosis in every follow-up, which was not increasing. The ampula monitoring was prompt, and there was no activity, and the vision was stable. 2017 scans still the same. So 2018, the vision slightly dropped, and there was a slow progressive diminution of vision, and the cataract surgery was planned as the cataract had progressed. And again, before the cataract surgery, the left eye cataract surgery was done, uneventful phaco. And before the cataract surgery, FFA was also done to just rule out any possibility of any activity in the eye. And as you can see, there's just staining of the old lesions of the drusense and of the scarred CNVM, but no activity as such. Again, after 1.5 months, the patient came grudging, complaining, shouting, and the patient had drastically dropped because there was an activation of the CNVM. There was blood, and you can see at the superior part of the fovea, in between, at the edge of the scarred CNVM previously, there is a fresh bleed, and you can see the FFA, and there is activity on the angiogram, and this fluid, and there is activity. So left eye intravitreal injection ranibizumab 0.5 mg was injected, again 3 loading doses and PRN thereof. And the last follow-up, again there was activity. The patient responded very well, but then she dropped out because she was not being told how many injections would be given in the future. And this was the last follow-up when the patient dropped. So to summarize, in the start there were some studies like Beaver Dam and Blue Mountain studies which postulated progression of AMD in association with cataract surgery. But lately, all the studies, even the ARID study and all prospective studies also do not find any correlation between cataract surgery and AMD progression. So the common consensus is it does not. So cataract surgery is commonly performed in AMD patients, we all know that. And every cataract surgeon and retina specialist has seen patients that undergo cataract surgery. And these things happen in the post-op period. So mostly that is because of undetected lesions preoperatively, or because of the cataract is dense enough, so there is a suboptimal macular view and lack of high resolution imaging like good OCT or good OCT angiography or ICG. But if you remove that bias from the equation, there is a very low incidence rate of neovascular AMD development between 1 week and the first year of cataract surgery. And of course, a preoperative VR workup, proper consenting and prognostication is very important, especially in your premium IOL patients. So just to highlight, case 1 was a development of a new lesion with activity after cataract surgery. Case 2 was reactivation of a quiescent lesion. So the common denomination being that both these patients did not have any activity for a couple of years before the cataract surgery was performed, and immediately post-operatively 1.5 months, 2 months, they developed the activity. So that might be coincidental, but it's very difficult to convince the patient of the same. Thank you so much.
Thank you, Vishal, for an excellent presentation. And I think you are the opening batsman for this session with all the case presenters. And this is a very, very important aspect that every cataract surgeon comes on. We are dealing with the senile population. They have RP changes. They have the drusen. How seriously to take it? How seriously to take it? How to monitor? What investigations preoperatively and the follow-ups thereafter. Home Amsler, anti-VEGF as and when required, and antioxidants, the roles. So here we have our three discussants, Professor Namrata Sharma, we have Dr. Rajiv Chaudhary and Dr. Hemant Murthy to discuss. Please.
Very well described by Vishal. It is a very common problem with the anterior segment surgeon having a small dry RMD, and we many times it is neglected. So it has to be decided at what time to be operated if it is a cataract early, the cause of the vision loss because of the cataract or because of the AMD, and sometimes that patient didn't get operated, and he feels that deterioration of vision is because of the cataract, and there is an increase in AMD. So monitoring, if patient is not willing for surgery, it is to be advised EMSLR, and it is to be properly explained that he has a two problem, not only cataract, he has an AMD also, which is an early stage. We may be dry or you have done the OCT, and it needs follow-up for the AMD also, not only for the cataract. And same is with the what explained that it can precipitate and it will blame the intersegment surgeon that surgery is the problem. So counseling is most important in this, that you are this cataract surgery is not going to deteriorate, but that AMD or that macula may deteriorate, and later on it has happened in the 1 month. It may happen after 4 to 6 months, and he come with that you are operated and it is because of this. So that requires proper counseling and proper follow-up also, and that Vishal has done very well.
Hemant Murthy, sir.
Yeah, Vishal, good representative cases you have shown. Some things that, the first case was primarily what we come across, a patient of dry AMD who had some PEDs, who developed, new lesion after surgery. On my part, I would probably like to do some other tests, like was what Dr. Atul Kumar was mentioning about either doing an OCTA in those cases to find out whether there was the activity that we observed was primarily due to neovascularization or just a post-cataract, some fluid that occurs after cataract surgery. The second case is a known problem that we encounter, that is patients who are of previously known cases of AMD. We need to tell the patients that this lesion could reoccur anytime. It could be, in the natural course is just the same. For that patient, probably it was quiet for some time, but then recurrence is always known. So we always tell our patient, be ready for the recurrence. Cataract surgery is just one part of your, the course of events. It is unlikely that the cataract surgery is going to alter your problem. It is in the natural course. So you have to be ready for this recurrence and get it treated as and when it recurs.
So can I make a point here?
Yeah.
So I just purposefully took the cases 4 years back. At that time, we did not have a OCTA, and that condition, is reflecting on our anterior segment colleagues' OPD, in which a higher end machine like OCTA is not available generally. So they do, of course, most of them, of course, have a OCT. So OCT will not tell you the full problem, and they, of course, serially follow up the OCT scans. But that is the infrastructure they have. So the point is, if such lesions are there in the preoperative fundus, you should get a serial follow-up with the VR surgeon. Just not look at the scans and see that there's no fluid and go for a cataract surgery. So that is the point we want to make here.
Correct.
Namrata ma'am, your views?
Vishal, I have a question for you. Again, excellent cases. You are from our institute, and we are always proud of you. And it was excellent set of cases. I wanted to ask you just one question. Are there any studies to show that the dry ARMD will go into a wet ARMD? And again, this is from the cataract surgeon's perspective. Dry ARMD will go into a wet ARMD if you do cataract surgery. Is there some?
Yeah, so that I mentioned in my penultimate slide, madam. And in that, all the studies which related cataract surgery with progression of dry AMD were, in 99 or in the early 2000. Because at that time, I feel that they did not have the scanning modalities which we have today. And they used to miss the occult membranes which could not be seen by fundus examination and then prevalent OCT scans. But most of the studies in the last decade do not show any correlation with the progression.
And does dry ARMD have greater propensity for cystoid macular edema? And what if a PCR occurs? Do you think the occurrence of a complication would hasten the macular pathology?
Yeah, so intraocular inflammation, of course, can increase CME. So the bias of complicated surgery has been removed in this presentation. So if you have a complicated surgery, n number of things can go wrong. You can have cystoid macular edema without any pre-existing dry AMD also.
And would you have done a fluorescein angiography? I think Dr. Hemant Murthy also asked you the same thing. Would you have
angiography was done in both the patients, but in 2016 we did not have the OCTA at that time. So presently I would have done an OCTA also to see any lesion which we are not seeing on a angiogram or a OCT.
Vishal, if that,
Partha, I would just like to congratulate you. Never in a physical hall can you get so many retina surgeons and cataract surgeons together. Because cataract surgeons are running in their cataract
They
halls.
don't go along very well.
Yeah, retina surgeons in the retina hall, and you can never think of a session, like this in a physical hall.
Virtually together.
Congratulations to you, and congratulations for getting, everybody together on one
Thank you, ma'am. Thank you, ma'am. Vishal, I had a question for you. Now, suppose the degree of cataract or severity of cataract is so high that you are not able to do an OCT of the patient. How are you going to counsel the patient if we don't know the fundus status? How are you going to counsel this patient? Number one. Number two. Yes. Second question. Is cataract surgery going to worsen? I mean, from dry AMD to wet AMD, if it is an uncomplicated cataract surgery?
Okay. So your question number one is how would you counsel if there's no proper fundus view? So not just in AMD, in every case in which you think or you have a doubt that there is a fundus pathology, I always tell my anterior segment colleagues, okay, get a fundus examination done by a VR colleague, and even if he or she cannot see the fundus, then you just mention the words like preparatory, phaco, and guarded visual prognosis, and a proper consenting before the surgery to keep you safe, and a possibility of anti-VEGF injections or surgery, oblique surgery, in the post-operative period. That prepares the patient a little bit of the post-op outcome. Of course, sometimes if you frighten the patient a little more, the patient might drop off. But it's better than the mental trauma you face after the surgery, especially in premium IOLs. So whether it's diabetic retinopathy, whether it's AMD, just mention the words preparatory or anti-VEGF be required in post-op period and guarded vision.
I think Vishal, most of the cataract surgeons are well versed with the 90D. They do a 90D examination and they're not able to see the fundus clearly.
I would differ from that.
No, Vishal, 1 minute. Vishal, let me come to it. Let me finish it. Instead of a 90D, if we encourage our cataract surgeons that if you're not able to see the fundus with a 90D, use an IO. That will give a better clarity of the fundus.
Absolutely.
That is the ideal situation, but unfortunately,
that's the message I want to give to the cataract surgeon. That's the message I want to give the cataract surgeon, that 90D is not only into 20D is not only in the arbitrary or the VR surgeons. Even we cataract surgeons should start using it.
Exactly. Everybody should be well versed.
Second question, Vishal.
Doubt, no? Refer to the retina surgeon wherever.
Yeah, that's true. Vishal, second question.
Second question was the same as Dr. Namrata Madam's question, that is there an evidence of progression? So right now, there are no studies correlating a progression of AMD with cataract surgery.
Okay. Thank you, Vishal. So we move to the next presentation.
One question.
Yes, Rajiv sir. Yes.
Is family's tree or other eye fundus will help?
Definitely, sir. Because most of these cases,
then we probably better assess that. And many times now patients
if the cataract is dense enough, you can see the other eye in the cataract. Yeah. But the point is that you do not advise the surgery the next day and do it. Keep the patient for a follow-up for a couple of months. Get a couple of VR consultations, and the patient is also then prepared, and the surgeon is also prepared for the outcome.
Okay.
Dr. Mohan, you had a question?
Yeah, I had a question for Vishal. A lovely presentation, Vishal. I just want to know the second case. There was a pre-operative fundus photograph, which I thought there was a small membrane there that probably became active. So this is what we have to keep in mind when we have a cataract surgery done. When we have a subtle membrane, occult membrane, that could have become active post-operatively. This can occur.
Yes, sir. I mentioned that it was a scarred membrane, and pre-operatively an angiogram was also done, which showed no activity. But these things can happen. The activity can be, so if it happens 1 year afterwards, the cataract surgery, then it's okay. But if it happens in the immediate post-op period, then the patient will be hell bent on suing you. So that's the problem.
Thank you, Vishal. So